proposed. So thank you very much, all of you in West Bengal Orthopaedic Association for the opportunity. Let me introduce people who are not quite familiar with me because I left country a long time back in 1995. Before that, I did my diploma in orthopedics in 1982. So many of you were not even in the med school at that time. And I did my MS together with Madanda. That was in 1985. And the year next, I did 1986, I did my diploma of DNB. And after a long gap, almost 10 years, I did MCH, which is equivalent to MS, but taking all over again 10 years later. But I'm a slow learner, so as if that learning was not enough, nearly 20 years later, I had to take the MS exam again in America to do my American board. And it's a continued learning process. So my recertification exam is taken every year from 2019 till 2023. And today, after this course, I'll have to take my another recertification exam. So you can understand that examination and learning, it's a continued process. So I will start with the history physical and how we do with the spine exam. First, you do the history like for any other patient, and you do exam, and you start with the inspection from the front, from side, and also from back. And then come palpation, and you palpate the spine right from the neck all the way down to sacrum. You also do the paraspinal area. Then you move like your movement of the spine, cervical spine, thoracic and lumbar spine, extension, flexion in all direction. And I won't go into the detail. And you look, when you look for in spine, you can look for a hairy patch like spina bifida or a Caffarella spot. These are all learned in the undergrad course. And next to that comes measure. And in spine, particularly in the lumbar spine, the movement can be contributed much from the hips. And therefore, there is one Schober test that isolates movement coming from the lumbar spine as opposed to from the hip. And that is done by identifying the level of the posterior superior iliac spine. You palpate it there, and then you mark that area, and then 10 centimeter above, 5 centimeter below, you make 2 more marks. And you measure the distance and ask the patient to bend forward and see how much these two distances are increasing. It normally increases by about 20 centimeters, but there are a lot of fallacies in the test. If the person is too large, too plump, a lot of fat, it becomes much more inaccurate. After you do the measurement, then you look for gait, and we will look into different gait later. And then you do the special test. In spine in particular, you do SLR. What is important, what the examiner will be looking for, that when you perform the test, that you are the examiner is looking towards the patient's face because it can reproduce pain, and that's what you're looking for. And also, once you get that the patient pain level or comfort level is reached, you get down a little bit, and then you try to reproduce the same by dorsiflexion of the ankle. This is for sciatic nerve stretch tests. But the femoral nerve components are not stretched, they are in front, so they get rather relaxed. So you do prone position and bend the knee, extend the hip to stretch the femoral nerve. So that's called femoral stretch test. And once again, these are very common. So I'm not going to go to the detail of it. You do the neurological examination, all the dermatomes and all the muscle groups like L4, you test for the quadriceps. You look for L5, particularly the EHL, and also toe and ankle dorsiflexions. EHL in particular, primarily supplied by L5 nerve root. The plantar flexors for S1. And then what is more important, that as the patient to walk on heels and on toes, check for L5 and S1 nerve root. These are very important part of it. And now I'll give you a flavor how I do it, like how I do the history taking, and then examination. So here, if you see the history of present illness, we record everything there, like when you do a long case and you have recorded family history, past medical, past surgical, etc. But when you are presenting a summary to the examiner, you see here the history of present illness, this healthy young man of 29 who works in a warehouse, including lifting, carrying weight, and that kind of a job, was seen with 3 months history of back pain, right L5-S1 sciatic pain that started 3 months back insidiously. And then the pain can vary from time to time. It is intensity of pain is 7 out of 10. Whether he received any treatment during the last 3 months and what happened to that treatment outcome. And what's happened during these 3 months is progressively getting worse to the point that he also has weakness and numbness in right S1 and L5 distribution. Minimal left leg pain. So important negative features have to be presented too. His general health, the childhood asthma, whether he has got any smoking history, diabetes, cardiac disease, etc. So that's in a summary in one paragraph that within 2 minutes you can present the entire case. Again, in the physical examination, like we described earlier, like he was sitting comfortably, he was taking some time to get off the chair. He also needed some time to stand erect, that to describe that how he is able to from sit to stand, how he's walking. He's walking with an antalgic limp, so that's a gait. And movement of lumbosacral spine, the special test like SLR that we described earlier, the neurological examination, reflexes, and also the unrelated part of the spine, like this is a lumbar spine case. We have few words about the cervical spine and neurological test. And then comes the summary. This is very important part. The examiner is going to wait to hear that how you can assimilate all the information you gather into few lines. In summary, this otherwise fit and healthy 29-year-old gentleman who normally engages, like what is job like? He's a warehouse job. It's 3 months duration of history, back pain and right leg pain more than the left leg pain, and in which nerve root distribution. What is the salient neurological picture and what does the imaging studies show? So this in a nutshell gives that you can summarize what you wanted to say. And here is another patient where you start little differently, like in history of present illness. Again, is a 63 is the age and sex, 63-year-old gentleman who is muscular, etc., and does this kind of job. And then in year 2000 had past back surgery following a work-related injury, which is a very important point, and that's why you go back, and that involved a right knee injury that almost left like a knee fusion, and now presents with 6 months history of back pain. So sometimes the background may be very profoundly important that you put in a brief way in front, and then you come what problem the patient is presenting with. Here is another person, 40-year-old right-hand dominant lady. This is very important for the cervical spine cases, that what hand dominates, right or left hand dominates. Not as important for the low back and the leg pain, but in upper extremity, it is very important which hand dominates. So occupation and hand dominance should come first as you are presenting after age and sex of a cervical spine case. 40-year-old right-hand dominant lady who works in a desk job, or it could have been that works in a manual job, etc. And then it presents with what? And that becomes very important in cervical spine patient. Now let us go into some of the problems that after history physical that we come across. Now this is a patient, and this shows an MRI scan, and it shows that predominant problem is like it's standing proud at L4-5, just below that level, is a cyst there. And that can cause the nerve root. And what nerve root it will take, L4 or L5 or S1. Now this is L4 nerve root that comes under the L4 pedicle that already comes out compared to this area. This is L5 pedicle. So nerve root here will be the L5 nerve root coming out. So more than likely, it will get the L5 nerve root symptom. Here is a cervical disc herniation. The disc herniation is pretty much central. This is an exit foramen. This is the other exit foramen. Here also you can see the spinal canal is average size, but there's a kyphosis and the disc is right sitting on the spinal cord. So the expected symptom here, it will be mostly like a myelopathic symptom, which doesn't cause much of pain, but cause more spasticity, weakness, unstable gait, etc. But not much of pain in the arm. As opposed to in this case, here is multilevel and there is tightness in the nerve root as well as in the spinal cord area. So you can get a combination of the radicular pain in the arm, weakness in the arm, and also weakness in the legs with cervical myelopathy. Now, Rajiv, can you comment or is it interactive? Like, can I get some feedback from the participants?
No, sir. They are on YouTube. They will ask questions from YouTube, sir. After your lecture, we will put questions to you.
Oh, okay. So
yeah.
It will be didactic. Then let me go forward here.
Yeah.
So the disc herniation and which nerve root you expect symptom is very important. Here, this is a sagittal cut in a parasagittal, like towards the right side, as you can see from the axial cuts. And this is an exit foramen. This is the left-sided exit foramen. This is right-sided exit foramen. And this is at the level of the disc herniation, which is like, this is C1. I'm sorry, it looked like this is C1, this is C2, 3, 4, 5, 6, 7. So this is between C6 and C7. If it is between C6 and C7, which nerve root it should take, C6 or C7? That becomes a problem to know the anatomy. The nerve root of C6 comes above C6 level. So the disc herniation between C6 and C7 will take C7 nerve root because C7 nerve root is just above C7 transverse mass. So this will take the C7 nerve root. So if this is a C6-7 foraminal stenosis or disc herniation, it will take C7 nerve root. But the anatomically, the C6 nerve root goes above the C6 vertebra. In the lumbar spine, the anatomy is very different. The corresponding nerve root goes below, like in cervical spine, C6 nerve root is above lateral mass of C6. But in lumbar spine, say L4 nerve root is not above L4 pedicle, it goes below L4 pedicle. But when it comes that you get a disc herniation, say this is L5S1 disc herniation, this is L5S1 disc herniation, which nerve root it should take, L5 or S1? Although L5 nerve root comes under the L5 transverse process or pedicle, but that will be here. L5 is already out. That's why this disc herniation cannot take this nerve root. So it will cause pressure to the S1 nerve root here. L5 nerve root is already out here. This is L5 nerve root. So in lumbar spine, although anatomically the nerve goes above the corresponding pedicle as opposed to cervical spine, in lumbar spine, nerve goes below the corresponding pedicle, like L4 nerve root is below the L4 pedicle. As opposed to cervical spine, C4 nerve root goes above C4 transverse mass. But still, it is the nerve root lower that gets affected by disc herniation, be it cervical or lumbar, like C5-6 disc herniation will take C6 nerve root, or C4-5 disc herniation will take C5 nerve root. In lumbar spine, L4-5 will more than likely will cause L5 nerve root. That's because of the anatomical variation, because the corresponding nerve root, although it's coming below that pedicle, but it comes out way out before the nerve can take it. That's called exiting nerve root. And here the nerve that is affected is called traversing nerve root, meaning if this is L5S1 disc space, the L5 nerve root already exited, not getting affected by the disc herniation, whereas the nerve here is called traversing nerve root, which is S1. and on the left side, S1 nerve root being affected by L5-S1 disc herniation. I hope it is clear. I'll expect some questions if it is not clear. Now, let me go into a little more detail that which disc herniation and which location of the disc herniation cause what kind of symptom. Normally, so this is L4-5 disc. The disc herniation is paracentral. This paracentral disc herniation is the commonest, and it doesn't take the nerve root. Like if this is L4-5 disc, this is L4, so this is L4 pedicle, the L4 nerve root is already exiting, so this disc will not take the L4 nerve root, but this will take the traversing, which is L5 nerve root. That is very conventional. Like here, this is L4-5 disc, this is a paracentral disc herniation. It takes the L5 nerve root because the L4 is already exited. On the other hand, when the disc herniation is further lateral, called far lateral disc herniation, like here, it is very different. It takes the exiting nerve root. And like here, this is an extraforaminal or foraminal disc herniation. That takes the exiting nerve root. In that case, L4-5, foraminal or extraforaminal disc herniation, will affect the L4 nerve root instead of L5. And not only that, that pain is a lot more severe. And why? Because it is the ganglion that lies there. See, this is a pedicle, or this is a pedicle, and this is foramen. Between this pedicle and that pedicle, this is the foramen. And in foramen lies this part of the nerve root, which is the ganglion, the most sensitive part of nerve root. It causes a lot more severe pain and lot quicker weakness and numbness in that nerve root. And this is another example, like it is the ganglion that comes just below the pedicle. So if the disc herniation is into the foramen, that will take the exiting nerve root into ganglion, cause a very different kind of symptom. Now, the location of the disc also can make some difference. Traditionally, the disc herniation is at the same level of the disc. And this is the axial cut of the MRI scan, and this shows the disc, the dark periphery, bright in the center in T2 weighted images. A paracentral disc herniation will cause, if it is L4-5, will cause L5 nerve root compression because L4 nerve root is already out there. But sometimes the disc herniation, this is called protruded disc, is bulging, but sometimes it gets disconnected from the originating disc and it lies further below. Say this disc actually originated from L5-S1, but migrated behind the vertebral body. This is an extruded disc fragment. Here you can see the axial cut is actually bone. This is not disc. And this is lying behind bone, behind L5 vertebral body. And depending on which location the extruded disc fragment is lodging, it will cause the symptom of the corresponding nerve root. Okay. And this is an example of a foraminal disc herniation. This is the traversing nerve root. This is L4-5. So this is L5 nerve root traversing here, but exiting nerve root is L4, is affected by the foraminal and extraforaminal disc herniation. This is another example of, this is the truly extraforaminal disc herniation, and this is L4 nerve root. This is the normal L4 nerve root that is on the right side, but on the left side, the extraforaminal disc herniation, and this is the L4 nerve root where it is pinching into foramen and outside the foramen. In cervical spine, the motor examination corresponds to different muscle group, and we have to be very conversant about it. C5 for deltoid, biceps, C5 and C6. What is most important is the wrist extension and flexion. When you do flexion of the wrist, it looked like a sign 7, like the letter 7. That's how I remember. The wrist flexion is by C7 and wrist extension is by C6. Finger extension and finger flexure, finger extension is long extension by C7, whereas finger flexion and all is C8, and small muscles in the hand, lumbricals, etc., they're T1 nerve root. C8 and T1 supplies the small muscles in the hand. You also look for, in cervical disc herniation cases, for some long-term effect like muscle wasting. And here the person has thinner muscle wasting. and it can be from C6 nerve root, but it can also be from some peripheral nerve damage, like say median nerve is a common cause for thenar and first web space wasting. You can also do some special test for cervical spine because the pain can come from the shoulder, but here this is called Spalding maneuver. That person turns the head and tilts the head towards the side of pain. Say this is left-sided arm pain, and is that arm pain coming from left shoulder or coming from the neck? You ask the person to turn head to the left and tilt towards the left, and then apply some axial compression, and that will reproduce the left-sided arm pain, telling you that the left arm pain was coming from the nerve root in the neck rather than arising from the shoulder or arising from the elbow with the cubital tunnel syndrome, etc. Limited sign is a different kind of sign that if you suddenly ask the person to flex the neck, he get an electrifying sensation in arms and legs called limited sign. You also have to rule out a symptom that can come from shoulder, elbow, as I was talking about, like this is a test for the empty can sign or Job's test for rotator cuff tear. Here's supraspinatus tear drop arm test, that if you ask to extend the arm 90 degrees and supinate the arm, and you just let the arm go, and if you cannot maintain it, it just drops, it called drop arm sign. These are more specific for the shoulder, and when you get some classes on shoulder examination, you will find. But my job here is to emphasize that you have to check not just the cervical spine, but shoulder, elbow, median nerve pathology, and all of those. Like these are phalanx test or Tinel sign or pressing the compression to the median nerve that can cause symptom. You have to rule these out clinically. And even if you are sure that the symptom was coming from the cervical spine, that you have completed your exam by examining the shoulder and examining the wrist for other pathology, that can be an important differential diagnosis. It's very important to complete your exam and also to impress the examiner. And I can give an example. In my MCH examination, the patient had a foot drop, and it was all pointing towards as if patient has got spinal problem. And I fortunately looked up the shirt and saw the examination behind the hip, and I found there was a scar for posterior approach to the hip joint, and that caused the foot drop, and it was not from lumbar spine. So these things become very important. In carpal tunnel in particular, it comes very close to the cervical spine, and we often refer patient to the neurologist. This is an important classification that you can confirm the carpal tunnel syndrome by doing an MRI scan or nerve conduction velocity or an ultrasound. But this CTS6, carpal tunnel syndrome, 6 clinical signs like numbness and the night nocturnal pain, the thenar atrophy, positive phalanx test, 2-point discrimination, and Tinel sign, they're all given some points. And if those points comes more than 12, the diagnostic accuracy almost matches any of the other tests, like your conduction, the MCV or nerve conduction velocity study or MRI scan, almost become comparable diagnostic significance. That's why I put that slide in here. And the nerve is not only affected in the carpal tunnel, it could be in the anterior interosseous nerve, and you can look for other nerve testing. The peripheral nerve testing is a different topic altogether, like Benedictine sign or the OK sign, that you cannot make an OK if it's an anterior interosseous nerve injury as opposed to carpal tunnel syndrome. These things are important to keep in the back of your mind. The special test for the lumbar spine, it involves the SLR. The first 30 degrees of leg raising should not cause pain, because that is the time when you are just making the nerves little stretched. And beyond 30 degrees, it becomes more representative of the nerve stretch, or the L5S1 nerve root stretch, or the sciatic nerve root stretch. If it is positive beyond 70 degrees, but not positive between 35 to 70, then you look for some other cause, like are you flexing the hip joint too much, and is it coming from the hip joint as opposed to stretching the sciatic nerve? On the other hand, if the hip joints are normal and it is not pain coming from the hip joint, it can still represent nerve root stretching sign, but it is weakly positive that you have to stretch the nerve root too much beyond 70 degrees to make it positive. To confirm that it is coming from stretching the sciatic nerve rather than from joint or anything else, you can do that. Once the moment patient starts getting discomfort, you let it go down a little bit and then dorsiflex the foot to reproduce the symptom. Or this is called Braggart sign, if someone is interested in the names. Or you can also do the bowstring sign, like get the patient's leg down a little bit and then press or bend the knee a little bit and press on the cervical nerve, and it can reproduce the discomfort. Or you can also ask the patient to raise the head. Again, you are stretching the nerve in the spinal canal without reinforcing from the foot end, and you can still produce the leg pain, and that's called Neri sign. Once again, a test for sciatic nerve pain. Remember, the femoral nerve is in front, and by flexing the hip, you are not stretching the femoral nerve. So if it is kind of to do is different. It's called to make the patient prone, bend the knee, and extend the hip. In that way, you are stretching the L3, L4 nerve root or the femoral nerve, and this is called femoral stretch test. You can also do the femoral stretch test in the side lying position, keeping the spine and the pelvis fixed, and then bend the knee and extend the hip in a side lying position. Another way of doing the femoral stretch test. And sometimes it is not the nerve itself, but it is the mechanical joint pain, which is a very common source of symptom. And this is one of the patients that I tested. Just listen.
Okay, tell me, where does it hurt you?
Right now,
Yeah.
right here,
Okay.
right around, right from here to here, and it hurts awful there. Now I got a leg ache.
Okay. Now face this wall and then try to bend forward the way you can normally do and tell me when it hurt. Can you go any further if you by taking some?
So what I wanted to say here is that this is called catching mechanical back pain, and it becomes even more prominent when the patient tries to get up from a forward bending posture. They get acute sharp catching pain, and this indicates more of an unstable lumbar spine disc degeneration causing discogenic pain or causing mechanical pain from the disc, and not by pinching in a nerve. If the nerve is pinched, you can get the pain continuously along the nerve, and you stretch the nerve, you can get the radicular pain. On the other hand, catching mechanical back pain, meaning you move your back in certain position and suddenly you get a very sharp pain, that indicates disc degeneration, degenerative listhesis, and all that kind of pathology. In younger person, spondylolytic defect, that can cause pain, and this is one way you can stress the spondylolytic defect by tilting the person to the side, say right-sided pain, ask the person to bend towards right side, and then try to extend the spine while pressing over the area of the spondylolytic defect where you are suspecting it, and then pull the shoulder back, twist the spine towards the right side. And in that way, you can reproduce the pain from an L5 spondylolytic defect or L4 spondylolytic defect, and can cause pain from there. You can also reproduce facet joint pain on that same side by this kind of test, and this is called Kemp test. Do not forget to check the gait, and this is a foot drop gait or called foot slap gait. This is an important, I think all of you know, so I won't go into the detail of it. And Trendelenburg sign and Trendelenburg gait is also very important. Normally, when you stand on both leg, pelvis is level. If you stand on right leg, then right-sided hip abductor muscle will pull the left-sided pelvis up. But if you stand on right leg, and instead of left-sided pelvis going up, it drops down, that becomes positive for Trendelenburg because it indicates the abductor muscle on the right side are weak and cannot tilt the patient upwards as it normally should. And as the pelvis drops down, the patient will tend to fall to the left side, so they will tilt their body towards the normal leg, and that is a common feature that you can check, and is that makes the pelvis compensated or parallel, but not quite up. But this also shows the patient had to compensate the Trendelenburg by putting the body weight on the other side. It's a very important observation that you need to check. The sacroiliac joint is another interesting area, and there are several tests to do the sacroiliac joint. You can do an axial compression, you can do a distraction, or you can push it, or you can also, opposite of that, push it together, compression of the sacroiliac joint. Here, if you press the sacroiliac joint with the right leg, that will be more specific for the right-sided SI joint pain when you are stabilizing the pelvis on the left side here. This is called figure of 4 or Fabet test. This is called Genslen's test. And also you can extend the, like a femoral nerve stretch test, you can do the same maneuver to extend the ipsilateral sacroiliac joint. And there is also direct tenderness over the sacroiliac joint. Once again, I'm not going to go into the detail of this test, but one need to remember that pain in the lower back does not always mean that it has to come from the lumbar spine or it has to come from L4 or L5 nerve root, which are the commonest problem area, but look for sacroiliac joint also. And a very common catch point comes, and you can be dragged into trouble by putting an X-ray, that this is an 82-year-old lady and has a lot of things. If you can see, that patient has a tilting and a very large scoliosis, and this scoliosis appears to be like with the listhesis of the vertebra that can cause impingement of the nerve root. There is a spinal cord stimulator. Patient has long-term pain, and the stimulator goes into the patient's spine. And all these are dragging your mind away, and they may tell you the patient has got left-sided leg pain. Patient has got a lot of left-sided leg pain, and you are thinking, is it the left-sided L5 nerve root or this nerve root? What's going on? Is it scoliosis causing pain? But do not get distracted by what is most prominent, but look into the rest of it. Here, you can see the ribs, but you can also see the hips. This hip is covered, unfortunately, by the spinal cord stimulator. And examiner can as well ask that does the patient has acute pain or a long-term pain, and that can drag your attention towards the spinal cord stimulator. They must have a chronic pain. But what is more important, look into the hip on the left side that has got quite advanced arthritis. So if the person has got left-sided hip and leg pain and cannot stand or walk on the left leg, it is not always radicular, but it can come more from the hip joint. You ask the patient to lie down, you see the Thomas test positive. As the patient lying down, the left hip goes up, cannot get the left hip down. Ask the patient to stand, and she comes with the walker for the back and leg pain. Of course, she has back pain because she has scoliosis and all those stuff, but that does not rule out pain coming from the hip, and you need to check it out. And let's see what patient does.
Right leg for me?
Patient is comfortable standing on right leg.
Can you? You are struggling.
So this is Trendelenburg positive, and also pain in the left hip is inhibiting the left-sided gluteal muscle to hold the pelvis on the left hip. So if you observe the gait, you will find an antalgic limp in the left leg and also Trendelenburg on the left side. And that indicates the primary problem is coming from the left hip. And also you can test for the hip, Thomas test and all other tests, range of motion test of the left hip, produce more pain rather than the lumbar spine, indicating that primary pain generated here is the hip, although spine can contribute to some degree of pain. Now let us go into some trauma. Cervical spine trauma is very common area, and you can see a plain X-ray and some of the lines that you need to check. First is that the soft tissue line here, the anterior soft tissue, then anterior vertebral body line, posterior vertebral body line, then spinolaminar line, then tips of the spinous process. They should make a one smooth curved line. The soft tissue shadow, until you come down from behind esophagus, it could be variable space, but from C2 down to C5 upper part, it's very close. It's no more than 4 millimeter from behind the esophagus, the vertebral body soft tissue. But when you go below L5, then the width of the soft tissue should be almost equivalent to width of the vertebral body. But if it is more than that, it can indicate some hematoma, etc. So this is about 15 millimeter, which is the width of the vertebral body. That is normal. But if there is an injury here or here, that can cause an increased soft tissue shadow. It can also show other features like break in any of the lines or increased gap between spinous process. More than 11 degrees is not an absolute number. What I wanted to say, if this gap is more than the gap above and gap below, that indicates some problem out there. And here is an example. You can see that there is a telltale feature of a break in this osteophyte or superior corner of vertebral body. There is a focal kyphotic deformity here. And also the gap between spinous process is much wider than gap above or gap below. Often they are very difficult to even identify. And these are the features that you have to look carefully to find out that is there any hidden trauma in the cervical spine, which is very common. And here again, very innocuous looking spine, but when you look carefully, that is something isn't quite right, flattening, and there is the posterior vertebral body line is broken, anterior vertebral body line is broken. The soft tissue shadow here should be 4 millimeter, no more, but it's kind of a little bit more over here. And if you look carefully, the spinous processes are out of alignment. The lower and the upper spine, they're out of alignment, indicating some problem going on there. And this is after reduction because the patient had a jumped facet or unilateral facet subluxation. That gives the twist, the tilting and twisting of the spine like a torticollis, and also unilateral facet dislocation, very difficult to identify, and this is after reduction. Unilateral facet dislocation can cause subluxation, but it is no more than 25% of the vertebral body. But when it goes more than 50% of subluxation, then you know there is bilateral facet dislocation. Again, a very common feature of cervical spine injury. An oblique X-ray can identify the facet, jump facet, but it shows only one side. So you have to do oblique views for both sides to know what is happening to the other side of the facet to identify facet dislocation. These days, we often do CT scan much faster to know what is the actual status. But if the plain X-ray is only available and you have to suspect from there, these are very common signs that you look for. A very important part of the fracture is when the entire spine is fixed, like ankylosed. Normally, if you break a spine in any place, the muscle spasm, rib cage, etc., will hold the spine to some extent, protect the spinal cord and neural element. But when the entire spine is fused like a femur, then wherever there is a break, that is the area it can only move, and it displaces way more than normal displacement. Like if you get a fracture here in a mobile spine, all the other segment will move and this part will move minimal. So it is reasonably stable. On the other hand, if the entire spine is fused, this is the only area it can move, they are a lot more vulnerable to displace. Oftentimes, the fracture could be just a hairline crack. Like here, there was a hairline crack missed in the original X-ray. Patient complained of pain 2-3 months, and then a repeat image shows that it is developing non-union. Why? Non-union is very rare in spinal fracture. They are spongy bone, they always heal. But if the entire spine is stiff, then the only movement can happen through the crack fracture, and that's where you develop the that is where you develop the non-union. When you see the fracture line, it looks like a spinous process fracture, but if you look carefully, there's a body fracture here. And that indicates a continuous line of fracture, indicates a lot more instability, meaning that needs surgical stabilization and immediate put in a collar until you stabilize, and it is very unstable. It is not always the injury that you need to discuss, but here, this is a patient developing rapidly on neurological status, and you find that there is something behind spinal cord and there is abscess in the epidural space. So this is a spinal epidural abscess, which is an emergent thing. So you have to look for other pathologies around. Coming to more degenerative changes, like here, there is stenosis, and in elderly, stenosis often have pacemaker. You cannot get any MRI scan, but here you can see the diameter of the spinal canal should be at least more than half the AP diameter of the vertebral body, where it is less than half, which is indicate a congenital narrow spinal canal. On top of that, there is further narrowing with the ossification of the facet joint capsule, causing further stenosis and causing neurogenic claudication and leg weakness. Here, on the other hand, the disc degeneration and facet hypertrophy, you see the large hypertrophy facet causing the spinal stenosis. And this kind of spinal stenosis can cause mechanical back pain less often, but more leg pain. And one can always ask that what is neurogenic claudication versus vascular claudication? It's a very common catch question the examiner with any opportunity will ask you. The vascular claudication both can cause pain after walking, but neurogenic claudication can be precipitated even by standing, where the vascular is not precipitated by standing. If the person just wait for a minute standing, the vascular claudication stops. But if you keep standing, neurogenic claudication pain doesn't stop. You have to sit down and bend the spine. The bending spine is the way that the neurogenic claudication gets relieved. But bending spine does not relieve the vascular claudication as promptly. There are other features of the peripheral pulses you do, the skin changes for ischemic changes, and also neurological testing for the numbness, weakness that can point towards the neurogenic claudication. But what I wanted to say that the distinction between vascular versus neurogenic claudication is very, very important. Next thing comes the degenerative spondylolisthesis. Once the disc is degenerated, it cannot hold the vertebrae in alignment and it slips forward, and it's called degenerative listhesis. So there is no defect in the parts. Where there is no parts defect, but the facet is arthritic, disc is arthritic, you get spondylolisthesis. It never exceeds grade 1. But if there is a lytic defect here, it can be even grade 5 or grade 4. It goes more than grade 1. It can be grade 1 only or less, but often it can progress if there is a lytic defect. Now, here what happens, you get a discogenic back pain, like the mechanical back pain I showed earlier, but also it can cause foraminal stenosis. So if you take a sagittal cut into foramen, you can find the foramen is tight, and you can get the nerve root in the exit foramen. Like if it is L4-5, it will take the L4 nerve root on the left side, on the right side, sorry, as the predominant symptom area. As opposed to that, when you get a lytic defect, then it could be grade 1 listhesis, but it can be even grade 4 or grade 3 listhesis, which doesn't happen without the lytic defect. What happens in lytic defect, the overall central canal diameter actually becomes larger. So it doesn't cause spinal stenosis in the center, but it can still cause some foraminal stenosis here. You see, the nerve root here is pinched because of the spondylolisthesis, the pedicle of the vertebra above comes to lie over the disc below, and the nerve is pinched over there. So again, if it is an L5-S1 lytic listhesis, there is no central stenosis. This is central canal pretty wide, no neurogenic claudication. But the nerve root can be pinched at the exit foramen, and that nerve root will not be L5-S1 disc herniation cause S1 nerve root, but L5-S1 listhesis will cause L5 nerve root symptom. That is important to remember. When you get the, this is called lumbosacral angle. It's a spondylolytic defect, and it causes some degree of kyphosis instead of lordosis. So the angle between lumbosacral junction or the should be 50 become much smaller. It can be even negative or reverse when the spondylolisthesis is large, and as it increases, the shape of the sacrum and L5 changes. So you cannot make a straight line like you can do in a normal sacrum. It becomes dome-shaped sacrum. Then you take the posterior and anterior margin of the vertebral body and measure the line of the superior border of the L5, which is more straight rather than the inferior margin. And that's how you measure the lumbosacral angle or in a dysplastic spine. This is grade 1, 2, 3, and 4. Like you divide the vertebral end plate into 4 zones, and compared to where the slipping vertebra is stationed, if it is moving forward, but within 1 quarter, you say grade 1 listhesis. If it is more than 2, 1, but less than 2,
Sir, we can't hear you properly.
I think there is some network issue.
Yes, yes. And
Some
his
network
video is
issue.
also placed.
So I think he has to. So by the time I think unshare the screen, you can. Oh, Dilip Gupta sir is calling. Hello.
Okay, our president is here. So Rajiv, please, if sir say a few words for us.
Yes, sir. By that time, Chinmay sir, please, you can say a few words. By that time, we can fix all this thing.
Yeah. So Arnav, unshare the screen or start. Kiranda, you can start sharing a screen. That will unshare. Oh,
Okay,
Sir is sharing a
yes,
screen. I think Sir is sharing a screen. So by the time some questions are there, Sabyasachi and Arnav, you can take questions from YouTube and you can throw to panel. We have Anil Jan sir here. We have Anito Sengupta sir here. I think Kiranda is also there. So you can throw questions right now.
There has been a question regarding the history taking. That is, during history, is it necessary to tell about the dermatome or better to talk about the region like calf or heel or something? What we should take in history? Any faculty can answer that.
Yeah, I think. Hello.
Yes, sir. Please.
Hello.
Yes, sir, I joined again.
I think the history should be in the patient's own language. Okay.
Okay.
So by the time
language.
is sharing a screen, Arnav, you can throw questions to one of the panelists by name.
Yes.
Yeah.
Okay. Dilip sir has started again. Sir, you need to unmute yourself.
Okay, I done that.
Yes, sir. Fine.
Can you see now?
Yes, yes, you can.
So I have done the major part of it. This is,
So we
can
can't
you see
hear
my
you.
screen? Can you see my screen now?
Yes, sir, we can.
Sir,
Please go ahead and
So this is now coming to the thoracolumbar fracture. The Denny classification is still the most commonly remembered and simple thing to say: compression fracture, burst fracture, flexion distraction, and fracture dislocation, where all three columns are gone very unstable. Even flexion distraction often is very unstable, but burst fracture may or may not be unstable. So any compression fracture reasonably stable, you do not have to operate. Any flexion distraction or fracture dislocation, more often you need surgery. But burst fracture, which is almost 50% of the total number of fracture, that is the difficult zone. It may or may not be stable. So it becomes important to understand the fracture classification. Is it mechanically stable or not, to understand burst fracture? And flexion distraction injury, the load can stay, or the axis can be inside the vertebral body, causing compression in front and disruption in the back. But if the axis of flexion is in front of the vertebra, then you may not see any of the fracture here, only the disruption of the vertebral body. That's called seatbelt injury. On the other hand, the similar injury, instead of going through the ligament, if it goes all through the bone, it is called chance fracture. It is not a fracture by chance, but it was described by Mr. Chance, which is an Irish doctor. So the chance fracture is a flexion distraction injury where the disruption goes to the vertebral body. Because it is all through the vertebral body, if you give a hyperextension brace, it can heal, but still it is an unstable fracture. But ligamentous injury at the back indicates it is mechanically unstable. So even if neurologically intact, you may have to do some surgery. ABC classification is propagated by AO. The difference between Denny versus AO classification is that in Denny classification, it is only morphology. It doesn't ask whether the patient had distraction, compression, or rotation, or etc. Whereas AO classification combine the morphology of the fracture, where the fracture is, which column is broken, and also how the fracture happened: compression, distraction, or rotation and shear. But still, the AO classification does not include the neurological status. On the other hand, to determine should we operate or should we not, we need to understand the neurological status. So further classification come called TLICS or TLICS classification, thoracolumbar injury classification system. That includes all three components, not just the column, but column and mechanism of injury. And also it asks for whether the patient has neurological deficit. And you can see the number, and it gives a scoring system to tell you if the score is more than 4, then it is possibly will need surgery. I won't go into further detail, but I would like to emphasize in one thing, because 50% of the fractures are burst fracture, where you have the question, is it stable versus unstable? An unstable burst fracture means where you find the kyphotic angle exceeds 30 degrees and or more than 10 degrees in thoracolumbar junction. Loss of anterior vertebral body height exceeds 50% of the adjacent vertebra, or there is canal compromise exceeding 50% of the canal diameter. If any of these three are there, that indicates the burst fracture, even in absence of posterior tissue disruption, is unstable and is mechanically unstable regardless of neurological status. If the person also has neurological deficit, then it also points towards more instability and may help you to determine should this burst fracture be fixed surgically, or you can treat it with a brace and non-operatively. Coming to scoliosis quickly, scoliosis can be idiopathic or can be secondary, like patient may have a tumor, infection, disc herniation, or neurofibromatosis, and so on and so forth. And those are called secondary scoliosis. And the large group of scoliosis is called idiopathic, where you do not find any underlying cause. And these are all idiopathic scoliosis. It can happen in children. In children, idiopathic scoliosis is very different when it happens below 4 years of age, because it can resolve, become normal, or it can become rapidly progressive, almost like a malignant growth. It is different from secondary scoliosis in children, which is called congenital scoliosis, like a hemivertebra or an unsegmented bar, which is not idiopathic infantile scoliosis. So if you see a scoliosis in infant, look for congenital anomaly. If not there, then you can call it early onset or idiopathic infantile. That can either resolve just by observation, or it can even grow very rapidly, only in 20% cases. That may need a complex treatment because you cannot do a traditional fusion surgery like adolescent scoliosis in kids. Between 4-year to 9-year-old, called juvenile, because at that age group, the curve does not resolve, but it has more time to progress. It becomes a problem, and you cannot still do a fusion surgery. And you may have to do a growing rod or something where, as the kid grows, a 4-year, 5-year-old kid will grow up to 10 years. Your spine will grow. So you have to allow the instrumentation to grow also, called growing rod technique. When the person is beyond 10 years, you call it adolescent. At that time, you determine whether the curve will remain small, like under 30 degrees when they become adult. Then you do not do any surgical treatment, either brace them or observe them or whatever. But if you figure out that the curve will exceed 45, 50 degrees, then you do surgery, because once it crosses 45 to 50 degrees, by the time they have achieved their complete growth, 16, 17-year-old, that curve will become symptomatic in adult type. So you rather treat it early. So in most cases, 45 to 50 degrees of curve are indication for surgery. That's about the adolescent onset. And once the curve is first seen beyond 18 years of age, you call it adult onset. Usually it happens in further older life, 40, 50 years of age. Now, a person with an adolescent onset scoliosis, say scoliosis diagnosed at 13 years of age and never operated, that will keep on growing even in adult life. So this is actually an idiopathic scoliosis in adult. The patient may be 50-year-old, but the scoliosis type is still idiopathic. As opposed to, more commonly you can see in adult patient called degenerative scoliosis, or it is also called type 1 adult scoliosis. What does that mean? That the spine was straight to begin with, even when they were 50 years old, and then the spine degenerates and lead to scoliosis. Like here, the spine was straight all along. Patient had spinal stenosis, someone did a laminectomy, and now spine is falling apart with the listhesis, etc. And now you can get a scoliosis. This is called type 1 adult scoliosis, where the spine was straight to begin with and is scoliotic because of some deformity. They usually come with not just scoliosis, but also kyphosis. They're usually elderly person. Oftentimes they had surgery in the past, a minor surgery, and leading to deformity. And this is the example of that same gentleman. Now, people can often ask the difference between adolescent, and I'll come to that later on. When you get an adolescent idiopathic scoliosis, besides spine examination we discussed earlier, something more to be checked, like the gap between the shoulder, the elbow and the trunk, and the list of the trunk, the plumb line compared from C7 as opposed to mid-sacral line. It's called coronal shift. And the level of the shoulder, which can be tilted one side, level of the pelvis can be tilted. And also as they bend forward, you can get a truncal inclination. These are the things you need to check in addition to other spine exam. You also should look for any cafe spot, etc. They mimic idiopathic scoliosis, but cafe spot can indicate that underlying neurofibromatosis, which can make the spine lot more rapidly progressive scoliosis, and also non-union is very high in presence of neurofibromatosis. Now, this is an example of two different patients. One patient had idiopathic scoliosis. This is idiopathic scoliosis in adult life. Whereas this scoliosis, the patient you have seen earlier, the spine was straight and has become scoliotic after laminectomy. How you differentiate? that in idiopathic scoliosis, the vertebra rotates at the apex. You see, it is very rotated. How you know the rotation? Because here, when the spine is not rotated, pedicles are equidistant from the spinous process. And as it is rotated, the pedicle changes. The two-side pedicle are not symmetrical anymore. But here, the pedicles are symmetrical because the vertebra is not rotated. This rotation of the vertebra in the apex indicates that this is an idiopathic scoliosis, as opposed to there is minimal rotation. You see the pedicle here, these two pedicle, more or less identical, more or less equidistant from the midline, minimal rotation. And that separates out that which one is type 1 scoliosis versus idiopathic scoliosis in adult life. There are few important definitions in scoliosis, that how you measure scoliosis or kyphosis by end vertebra. What is an end vertebra? End vertebra is, if you see the vertebra in the curve, the vertebra which is maximally tilted is called end vertebra. These vertebra, although towards the apex of the curve, they are less tilted than this one. So this is called end vertebra. What is a neutral vertebra? Neutral vertebra means there is no rotation. How you know rotation? You see the spinous process and pedicle. If the two pedicle are equal distance from the spinous process, then there is no rotation of the vertebra. That is called neutral vertebra. What is called stable vertebra? Meaning you see the mid-sacral line and the 2 point of the sacrum, you draw a line there, and any vertebra is bisected by this mid-sacral line. That's called vertebra in stable zone, way off the line. So this is not in stable zone. This is unstable vertebra, but this is neutral vertebra, not rotated. And here, this is called end vertebra. So it should be very clear in your mind what is end vertebra, what is neutral vertebra, what is stable vertebra. Because when you decide for scoliosis treatment, you may have to do how many vertebrae shall I fuse? Shall I stop at the end vertebra? Shall I include the neutral vertebra? Shall I go to stable zone and not? And scoliosis classification is a little more complex, and as I understand, may not be the discussion, but more or less our scoliosis was mainly focused into thoracic. So the deep curvature becomes ugly looking and people are more concerned. But the original classification doesn't consider the lumbar curve, and that's why the original classification that goes by the name of King classification has been modified by Lenke, and the Lenke classification is different. It has got 6 major classification types that include multiple thoracic scoliosis and also the lumbar scoliosis, and add 2 modifier, lumbar modifier and sagittal modifier. But I won't go into the complexity, but these are the 6 different major types of Lenke classification of scoliosis. You really need to go into the detail to learn it, and I don't like to make you more complicated. This is another very hot topic, but I do not know how much important from the MS General Orthopedics point of view. This is called sagittal balance of the lumbar spine, that if the person is standing and you take a lateral view of the whole spine, where the spine stands. And there are 3 different names: PI or pelvic incidence, which is the inherent property of any particular pelvis. It never changes regardless, however the pelvis is tilted. And it is measured in a way that you do a center of the hip axis, you do the midline of the 2 hips, and midpoint of the superior vertebral end plate of the sacrum. And from there you draw a perpendicular line, and from midpoint of sacrum draw the hip axis, and this is called pelvic incidence. That pelvic incidence angle is sum total of 2 other angles. One is called PT angle. If you draw a vertical line, this angle is called PT, and the slope of the sacrum, this sacrum to horizontal is called sacral slope. If you add the number of sacral slope and pelvic tilt, that addition will be same as pelvic incidence, or the formula is called SS plus PT totals to PI, or pelvic incidence. and pelvic incidence is always PI is like the principle is same for any particular pelvis. Whatever lateral view in whatever tilt you measure, pelvic incidence will always be the same. But as you tilt the pelvis, the SS will become smaller and the PT will become larger. So if this pelvis is tilted backwards, this line sacral will become more horizontal. So the SS will become smaller, but the PT will become larger. And that's how you understand that although person is lying straight with the sagittal plumb line dropping in the sacrum, but there is a problem because the pelvis is tilted backwards and that causing problem. So if I do any surgery, any correction, I have to get the pelvic tilt normal. And this PT therefore become very important. And here it shows two different PT. This person has a very large PT, this person has a small PT, but on an average, it is about 55 degrees. And other important factor that is that the PI or pelvic incidence of any person is usually same as the L1 to S1 lordosis. If you do the L1 end plate and S1 end plate, and the angle between L1 and S1 usually becomes same as the person's pelvic incidence. So if the pelvis is tilted and lumbar lordosis is flattened and you are doing an osteotomy to correct the lumbar lordosis, how big of a lordosis you will make? You will make the lumbar lordosis back to where the whatever the patient's pelvic incidence was. So if the pelvic incidence is 55 degree, but lumbar lordosis is flattened, you do an osteotomy to correct the lumbar lordosis between L1 and S1 close to 50 degrees or 55 degrees. So that's how these things become important. As the focus on lumbar and thoracolumbar sagittal profile, people have also looked into the cervical spine, that even if your cervical spine is fused, but the patients are not always happy. So what it is that if you drop a plumb line from C2, then from C7, it's called C2 to C7 shift. That shift, if it exceeds 16 millimeter, then it becomes like here is a 40 millimeter. In that case, the patient has to hyperextend the craniocervical junction just to be able to look forward, and they become chronically painful. So this is sagittal parameter of the cervical spine, all called C2 plumb line, should be within about 15 millimeter of the posterior margin of the C7 vertebral body. Once again, may not be important from MS point of view, but just to draw your attention to this side. These are the other things that you can measure in cervical spine deformity. One important factor is called chin-brow angle. If you get an ankylosing spondylitis patient, they cannot look forward and they'll always be looking downwards because even by extending hip or trying to extend the spine, they're all fused, they cannot look forward. So there, if you draw a line chin-brow, from brow to chin a line and a vertical line, that angle is called chin-brow angle. Normally, people should be able to look straight forward. But when it becomes below 0 degree, then this chin-brow angle determines that if you have to do an osteotomy in the steep cervical spine, what kind of osteotomy you have to do to make the chin-brow angle to neutral so that they can look forward. Otherwise, these people have got great difficulty looking forward. They can see only a few feet from their feet, but cannot see or cannot talk to you in forward. They can sit down, bending the hip, then they can look forward and talk to you. So this is about the cervical deformity, and lot of these are a little bit more difficult unless you are closely thinking about it, but I will recommend this book. And here is a, if you get my presentation, there is a link that you can download this book from internet for free. This is Radiographic Measurement Manual of Spine Deformity Study Group. That explains how you measure different parameters of spine, be it spondylolisthesis, be it scoliosis or kyphosis or cervical deformity or sagittal parameter of the spine. Everything is given a very lucid way, and also it tells you how you obtain the spinal parameters. I will stop by pointing your attention towards the implants that Kiran Mukherjee is going to talk to you. This is called first generation implant designed by Harrington, where only 2 points it fixed to spine. top end, bottom end, no other area. This is a modification, it's a Lukey wear. This is not original part of Harrington. This is called Lukey, where you get the sublaminar wear. This is called segmental fixation. This is second generation. And third generation is where you get the anchor point, not sublaminar wear and not just the hook. You can use the pedicle screw, hook, and hole combination. These are the three different generations of spinal implant. The problem with the first generation Harrington is that it is only on two ends, so hook can cut out or the rod can break because it has got notch in the rods. Whereas the second generation started in 1984. This is Yves Cottrell, who died a few years back, and this is John Dubose. He is still alive, a Frenchman. Yves Cottrell came to India in our Calcutta IWACON in 1985, when this Cottrell instrumentation was very new to the whole world. And he made a poster presentation during Park Hotel, the Calcutta IWACON conference in 1985. And I met him at that time. What it does that it also uses hooks. There was no pedicle screw or sublaminar wear, but multiple hooks, and each hook is connected to the rod. It's called segmental fixation, multiple segment instead of not only one Harrington hook at the top and bottom. That's called non-segmental fixation. The Lukey wear comes next step. Here it is also a segmental fixation, but still second generation implant. No pedicle screw. Pedicle screw is the third generation implant. These days we use a combination of hook, screw, even sublaminar wear, even sublaminar tape, making a difference so that it doesn't cut out a bone. And that's all I have for you. I'll wait for any question after we listen to Kiran.
Yeah.
And also Professor Anil Jain is waiting to talk to you. Back to you, Rajiv.
Yeah, thank you, sir. Arnav, we can take some questions from YouTube. Sabyasachi?
There are not many questions yet. We had a discussion on that question on history. There are two more questions regarding what is meant by complete and incomplete lesion and symmetrical and asymmetrical paralysis.
I think I will leave it to Dr. Anil Jain because I already spent too much time, and that is much more part of the paraplegia and what's fine. He will explain it.
Sir, please unshare your screen.
That's the most commonest part.
Yes. Sir, please unshare your screen. Yeah. So now I think we will have a talk of Dr. Kiran Kumar Mukhopadhyay. He will be giving a brief history taking presentation, and if time permits, I think we will have instrument at last. So Kiranda, I think we can start with your history taking presentation. History and clinical examination.
Thank you very much. Just a flow chart of how to have a clinical examination of spine in the exam. So these are the common causes which affect spine, but commonly in the exam we get only tuberculosis spine and also the PIVD cases. So before starting, these things you must remember that introduce yourself, ask permission to perform examination, explain the patient appropriately, and the patient must be exposed properly, and tell the patient to let you know if anything you do is uncomfortable or painful. And when there is a female patient, make sure that the female nurse or assistant is present. So these are the parameters upon which clinical examination of spine is done. The first one is history, second is general examination, third is inspection, then palpation, then movements, measurements, results test, and also neurological. That's the final, and that's the most important. So history of the presenting illness, the chief complaint should be in a chronological order, and details history of the pain, swelling, weakness, numbness, or deformity should be taken. Regarding pain, the site, the severity, whether it's continuous or intermittent, the nature, the radiation, the aggravating relieving factor, or positional variation, or walking distance should be taken. And also ask about history of trauma, history of constitutional symptoms, history of hemoptysis, hematemesis, melena, history of respiratory symptoms, dyspnea, history of other joint involvements, history of pelvic inflammatory disease, any treatment history, any immunization history, and also full development history if from the mother, or if the patient can give you the history. The past history must be taken, similar complaints, prolonged drug history, previous surgery history, whether the history of diabetes mellitus, hypertension, or taking drugs for tuberculosis, hematological disorder, or any neurological disorder. And also take the personal history, which includes the smoking, alcohol, drug addiction, taking the diet, the blood oil habit, the appetite, the sexual history, and also the menstrual history in females. And in the family history, if the similar illness in the family, or is there any contact history of tuberculosis must be taken. Regarding general examination, we have to do a head-to-toe examination. We have to take weight, height, neurocutaneous markers, ligamentous laxity, clubbing, cyanosis, pallor, or lymphadenopathy. And then coming to the examination of the local spine, we must talk about the log roll technique, because in case of Pott's spine, we are not allowed to move the patient inadvertently. So it's a must to know how to change the posture of the patient during the examination, and you must take the help of an assistant, and you must know how to do a log roll technique properly. So during inspection, the local examination starts with standing, then lying down. Standing is not allowed if it's a case of Pott's spine with minimum amount of neurodeficit. A gait is also not done in case of tuberculosis spine, but it can be done in case of EIVD. So in the initial phase of tuberculosis, the gait is painful. That is the cautious gait, that is short steps gaits, and there may be a tripod sign in thoracolumbar tuberculosis. And in ankylosed spondylitis, there is a high stepping gait, and there may be a hypotonic or spastic gait, or there will be a bilateral foot drop, there will be a hypotonic gait. And we should look for the attitude and deformity from lateral aspect and from anterior aspect regarding the kyphosis, the curves, the knuckle angular, whether this is knuckle angular or rounded, whether the lordosis is increased or decreased, and from the anterior aspect, the level of the nipples, the level of the shoulders, the chest shape, revamp, and the abdominal protrusion. And from the back, we should assess the position of the head, level of the hairline, length of the neck, and level of the scapula, level of the shoulders, deformity, is there any scoliosis deformity, the margin of the trunk, the spinous process, the iliac crest, the dimple of Venus, which overlays this costocerebellar spine, and the central midline furrow. And we should look for paraspasm, azospasm, muscle wasting, any swelling, lipoma, prolapses, all will be corroborated with palpation. The renal angle, the skin, and is there any visible step, is there any apparent shortening of lower limbs, and is there any visible pelvic obliquity. From the lateral aspect, I've already told this from the, and on palpation, we must start with the local, checking the local temperature, and then we should palpate all the spinous process. That is the screening of the painful vertebra, and the prominent spinous process, that is whether it is a knuckle, angular or round. The knuckle, we know that knuckle, when there is a one vertebra involved, angular is less than 3, and more than 3, there is a round kyphosis is seen. And is there any step if it is found in during the inspection must be corroborated. And there is one of the important steps is to elicit the tenderness. The tenderness can be elicited by 3 methods: the direct pressure, the twist tenderness, and the deep thrust tenderness. The direct pressure is elicited by direct pressure on the spinous process. If there is pain, it suggests posterospinal disease. If tender interspinal area, there is disc pathology. If there is a rotary tenderness, then we have to attempt to rotate. Or if we also to check for thrust tenderness. Or rotary tenderness is given by direct rotary strain at the base of the affected spinous process, or by exerting rotational movement in opposite directions to the disease and adjoining normal spinous process. And we must memorize all these levels. The C7 vertebra, C7 is the vertebral prominence. The D1, the most prominent spinal process. D3 is the spine of the scapula. D7 overlays the inferior angle of the scapula. L4 is the highest point of the iliac crest, and S2 is the pieces of the dimple of the Venus. The paraspinal spasm can be elicited by Kibler test, which is attempted movement of pinched overlying skin along axis of the paraspinal muscle will be restricted if there is a presence of pain. The muscle spasm manifests as a visible and a palpable painful contraction of the paraspinal muscles. All the things should be corroborated. If there is any cold abscess, we should look for where it is situated. Either it is the renal angle with the pedis angle or the iliac fascia. We should assess the size, margin, consistency, fluctuation, and also the lymph nodes. Movements is not important in case of examination in the case of case spine, because movement is not eliciting movement is not allowed in case of paraplegia due to case spine. But these are the movements that to be done in case of PIVD. There is the flexion movement is determined by the Oates test, Scobar sign or modified Scobar test. This is the Oates test, C7 and 30 cm distance. The flexion increase should not be less than 3 cm. And the Scobar test and also the modified Scobar test, these are to be done in case of PIVD. And cervical spine, there are the movements of flexion, extension, lateral flexion, and rotation. And on bending, look for the rib hump and also the chest movement. And one of the most important things is not to forget about examining the sacroiliac joint tenderness. So the measurements, I've already discussed the linear measurements from occiput to protuberance to tip of the coccyx, iliocostal distance, chest expansion, and the limb length discrepancy. And these are the special tests, the lumbar root tension test, all already vividly described by Dr. Sengupta. So I'm not going to details, but the only thing is we have to know about the interpretation of the tests. And these are the tests already described. And the test for SI joint also described by Dr. Sengupta. So I'm not going to details about that. And now come on to the last part, the neurological examination, and the most important part. So we should examine on the basis of the higher mental function, the cranial nerves, the motor, and the sensory. The motor neurology is examined on this following order. The first we look for the bulk of the muscle, and then we should look for the tone, then motor power, the immersive grading, then the reflexes, which are the superficial reflexes, and there are deep reflexes. The superficial reflex includes the abdominal reflex, immersive reflex, anal reflex, bulbar reflex, and plantar. And deep reflexes include knee jack and ankle jack, coordination, and also involuntary movements. The bulk of muscle is assessed by inspection and palpation. Notice the size, texture, consistency, and elasticity, and measure where the bulk is maximum. Tone is a state of partial state of contraction in healthy muscle. The degree of tone is estimated by handling the limb passively, and is called spastic when there is a clasp knife type of rigidity. That is the initial resistance which increases on increasing speed, then there is a sudden giveaway. So that is called spasticity. That is clasp knife. This is the MRC grading of the assessing the power of the muscles, the grade 0 to grade 5. Grade 0 complete paralysis, grade 1 a flicker or contraction only, grade 2 power detectable only when gravity is excluded. Grade 3 is when limb can be held against gravity but not against exogenous resistance. Grade 4 some degree of weakness is present, and grade 5 is normal power. And regarding the reflexes, for the upper limb, biceps, vertebralis, triceps reflexes are elicited, and the for lower limb, ankle reflexes and knee jack. The reflex also grade from 0 to 4. 0 is absent, 1 is present as if in a normal ankle jack. Grade 2 is brief, there is a normal knee jack, and grade 3 is very brief, and grade 4 is pronus. So eliciting ankle jack, the patient's leg is externally rotated with flexion of the knee. The foot is dorsiflex to stress the Achilles tendon, and the posterior aspect of the tendon is struck with a hammer. Plantar flexion of the foot and contraction of the gastrocnemius muscle is noted. So there is a visual contraction of the gastrocnemius muscle. So that is the and the knee jack, the examiner places is left. It can be done either in a supine position or like this picture on a patient sitting on a chair or a bed hanging with his leg. So the examiner places his left forearm under patient's both knees in order to slightly place them together. Then the joints are relaxed and heels falling on the bed. The patellar tendon is stuck with the hammer, and extension of the knee and visual contraction of the quadriceps is seen. Most important is to expose the quadriceps muscle is most important. Then the biceps jack, the triceps jack, the plantar conus. In a supine patient with extended lower limb, forefinger and forefinger and the thumb of one hand are placed just over the superior pole of the patella. Over the two sides of the quadriceps, a single stimulus is given by pushing the patella distally. If positive, a patellar conus will be apparent by repeated pulling of the patella towards the quadriceps, upwards by the quadriceps tendon. And the ankle conus, the knee and hip should be flexed to 90 degrees, and the one hand support the lower limb just below the knee. With the other hand, a dorsiflexion stimulus is given by the fingers placed at the forefoot. In case of upper motor neuron paralysis, there will repeatedly plantar flexion movement. So this should be placed under the knee, but never on the gastrocolius. And now coming to the abdominal reflex. The abdominal reflex is tested by striking the abdomen on the four quadrants, and it must come from outwards to inwards towards the midline. So there will be visual contraction of the abdominal wall, and the nipple line is T10, so above and below T9 and 11-12. The plantar reflex. This is one of the most important. With the muscles of the lower limb relaxed, scratch the outer edge of the sole with a key or a similar blunt object. A normal response consists of a contraction of the tensor fasciolata, adductor of the thigh, the sartorius, and on the further soleus, plantar flexion of the toes, and the dorsiflexion of the inversion of the ankle. And this is one of the most important pedagogy to assess if there is no stiffness of the great toe. So this is normal plantar. This is not Babinski. This is normal, and you start stretching from the lateral aspect up to the maximum, up to the ball of the great toe. So if there is a upper motor neuron palsy, there will be spastic, there is no atrophy, there will be hypertonia, there will be DTR will be increased, there will be superior reflex will be altered, and Babinski sign will be positive. And next, coming to the sensory, we must test the sensory on three aspects: the spinal, testing the spinothalamic tract, that is the ventral aspect, that the posterior column sensations, and the cortical sensation. The spinothalamic tract sensation are the superficial and deep pain. There is temperature should be assessed by hot and cold. Touch to be assessed by deep touch and crude touch, and posterior column sensations are important. There is a light touch. The deep touch is by spinothalamic tract, and the light touch is by the posterior column sensations. And the vibration sense should be assessed by tuning 128 tuning fork, and we must assess the position sense. For cortical sensation, we assess the stereognosis and 2-point discrimination. And for this sensory assessment, we must memorize these dermatomal distributions of the upper limb and the lower limb. And next, we should assess the bladder, whether is a upper motor type or a lower motor type, or is maybe mixed type. So lastly, we should determine the neural and vertebral level. This is also one important thing to memorize. In cervical, we should add, for neural level, we should add 1, D1 to D6 add 2, D7 to D9 add 3, D10 add D10 is L1, D11 is L2 L3, D12 is L4 L4, and L1 is all sacral segments. And lastly, we must not forget to do a PR exam. Thank you.
Kiranda, please unshare your screen. So excellent talk. I think a brief clinical examination. And Anil Jain, sir. Anil Jain, sir. I think there's. Please unmute yourself. Anil Jain, sir.
Rajiv.
Yeah.
Rajiv.
Yes, sir.
I have one comment regarding the history part.
Yes, sir.
That is that for the beginners, in history, in the back pain, one should take the referral pain. For example, patient having some pelvic pathology, and is there any back pain? Is there any relation with the posture of the patient? For example, patient has a pelvic pathology and a tumor, and she gets pain on supine position, but it is relieved on prone position.
Mm-hmm.
Okay, so that part of the history, whether it is related with the relation, is there any relation with the posture of the patient. That is
Yes,
number
sir.
one. And second part is that sometimes some old injury that can produce some neurological problem later on. For example, you see, I have one patient. Patient first presentation was a foot drop. From the history, I come to know that patient has a suicidal attempt and had some needle prick, attempt on needle prick, and those needles prick and damage the nerve roots. Later, patient had presented with the foot drop. So these sort of things, this history of abdominal any pathology or abdominal injury, that okay.
Yes, sir.
And
Yes, sir. Important
another
point.
point I just want to name this, while examination of the spine, the position of the back, is there any tilting, as Dilip has already mentioned something, but it is my question to Dilip as well. When the patient is tilting on one side, is there any, gives any clue about the location of the disc, whether it is a lateral to the root or the medial to the root? Is there, should it be noted or not?
Please
Hiron or
unmute yourself.
Okay.
Dilip sir, please unmute.
Okay, you have raised a very good question. Let me share my screen. Then I can bring you right over there, okay? And right now, screen has got an answer to another question, complete versus incomplete. It is incomplete. I'll come to your question, Madanda, soon. But there was another question. Incomplete means when there is any sacral sparing, anything remaining, little sensation left, little bit of a toe movement left, a little bit of a bladder function or some sphincter function there below the level of injury, that's called an incomplete cord injury, because those little things gives us some hope that eventually over time patient will get much better than what he is presenting now. On the other hand, if there is no motor, no sensory, no reflexes, and no bladder ball sparing, no sacral sparing, that gives a very ominous prognosis that this patient may not get better at all. Indicate a complete cord transection, something like that. The other important thing is that what is the Asia classification of the level of injury? The lowest segment with intact sensation and anti-gravity muscle strength, that is determined as the lowest segment. So the patient will have, say, a C5 injury or C6 injury. It depends on, say, C6 does wrist extension. So if the patient can do an anti-gravity wrist extension and has some sensation in C6, we will say it is a C6 cord level, because that one nerve root level in the cervical spine make a big difference in their ability of self-independence or independent activities of daily living. And now I'm going to switch my screen to this screen that what Madanda was asking. You can see this is called sciatic scoliosis. The patient is standing, leaning to one side. Can you see that?
Yes.
Okay, so here on the left-hand side, the disc herniation is over the shoulder. Yeah, and I can see my screen now. This is a L4-5 disc herniation, and this is L5 nerve root, and this is over the shoulder of the nerve root. Okay, and in that case, if it is over the shoulder of the nerve root, it will cause right-sided. If this is right side disc herniation, it will cause right-sided leg pain. And patient will tend to lean towards the left side to reduce the pressure on the nerve root. You with me? So that's why this patient has right-sided leg pain but tilting to the left side, or sciatic scoliosis to the left, because the disc herniation is over the shoulder. On the other hand, in the right-hand side, you see the L5S1 disc herniation in the axilla, which is less common. It is displacing the L5 nerve root, S1 nerve root laterally. So here, if the patient tilts towards the left side, he will pinch the nerve root even more. So he will tilt towards the same side. Does that make sense to you guys?
Yes, sir.
So Madan,
Yes.
does it answer your question?
Yeah.
Yes.
That
Yes.
I wanted that point should be highlighted.
Yeah, yeah.
Sure.
Disclosure.
So I think we can go through Anil Jain sir lecture on port spine, and then
Yes.
we will have question answer. Anil Jain sir, please share your screen.
Let me unshare mine.
Yeah.
Yes. Yes. Sir.
Anil Jain sir.
I think he has not unmuted his mic.
Yeah, but I think we can't see him also. Anil Jain sir.
I just talked to him 2 minutes back that he said that he was on there, but oh, this is Anil Jain.
Yeah, but
Oh,
name is
I
there.
cannot see him.
Is not
In the
seen
meantime, we
the
can have
screen.
some questions. So, Sen Gupta sir is there. Dr. Aniruddha Sen Gupta sir.
No, but let
Yes,
me
sir.
call.
Yes, sir,
You
please,
can
sir.
ask me question, but let me
Yes, sir,
call
please.
it.
Yeah. So, sir, there is a question.
Can I
So,
ask a question?
for power of muscle,
Give
whether
me
you should
one
test it in group or in individually.
Give me 1 second. Hey,
Yeah.
Anil. Hey, Anil, you are.
So, Sabsachi, you have any question? Yeah, you can ask.
This is a question from a PGT.
Yeah.
As the most cases are in our exam, MS exam, that is tuberculous paraplegia, that is compressive myelopathy. So there is a question, how will you localize the level of the lesion in these cases? What are the different methods of localizing the level of the lesion?
Your question is for two.
Anil Jain sir is there. We can see him, but we can't hear him.
Yeah. So, Aniruddha Sen Gupta sir, can you answer this
Aniruddha
question?
Gupta, sir?
Please unmute yourself.
Okay, can you hear me now?
Yes, sir. So
Okay.
please, you can take this question.
So the question is, I mean, how you find out the level of the lesion? It's usually the level of the sensory level, and motors are not as detailed mapped out, but certainly motor can help you. Not much in terms of paralysis, because in paralysis is in cord level, and cord stops at lower border of L1 or somewhere at L2. So from motor strength, it is difficult to figure out where the level of lesion is. But my clinical implication is to find out the sensory mapping at the level of cord compression. You will find suddenly there is hyperesthetic zone, and then it becomes diminished sensation. And that sensory mapping will give whether it is T10 or T7 or T8 is the level of that's the neurological level. Yeah. In thoracic spine, neurologic level is in the same level as the vertebra, because the nerve just exits, it doesn't go traversing downwards. So like a T7 nerve root will just come under the T7 pedicle, right? So if that is where the compression is, you will get a sensory change at the T7 dermatome. In the lumbar spine is different. The lumbar spine, the nerve goes further below and then it comes out. So an L3 nerve root may indicate that the actual compression is higher up, maybe at L2 or higher up there. But once again, it is the dermatome that helps us to find out what level the cord compression is, if the lesion is at the cord level. You do not get L3 nerve root lesion with a cord level lesion, because that will give more higher up in the spine. Does that answer your question?
Yes, sir. I think Anil Jain sir is back.
But it will help also clinically also we can, isn't it?
No, you can certainly do like say palpation, percussion, whether there is any deformity, all those things.
That will also help.
But if you do it, yeah, then neurological test can tell you where the spinal cord itself is being compressed. Maybe Anil Jain can highlight a little more.
Sir, Anil Jain, sir, I think his video is not coming. Some network issue is there. So sometimes it's static. His face is static and network issue is there. So we can have some more questions. Sabyasachi, if you have some more questions, please put it.
Let me call Anil again, okay?
Yes. So,
Whether you unmute
Hello,
yourself.
hello.
Yes.
Is there any role of zone of hyperesthesia or hyperalgesia or girdle-like sensation in determination?
Kiran sir, you can take this question.
The Sabyasachi network is also it's not working. I think again Sabyasachi network.
No, I can listen, but let Kiran take the question, okay?
Yeah.
Please repeat.
Hyperesthesia.
Sabyasachi, please repeat your question.
Zone of hyperesthesia or zone of girdle-like sensation for determination of the sensory loss.
That's true. I mean, it is not determination of sensory loss, but what happens when you get an incomplete cord compression, you get diminished sensation, not complete loss of sensation. But at the level where the cord is compressed, you can find a band of increased sensation or altered sensation. And that band-like sensation indicates which level the nerve root is being pinched, the spinal cord is being pinched. That is the level where the sensation changes from normal to dysesthesia or hyperesthesia and then become diminished sensation. That band indicates where the lesion is lying in the spine. Does that answer your question?
Yes.
Yes, sir.
Yes, sir.
Okay.
Any more questions?
Sir, how will you differentiate between compressive and non-compressive myelopathy?
Well, the non-compressive is a disease within the central nervous system, like a syringomyelia or a tumor inside the cord. And a little more different, particularly you can see a differential sensory loss. You may find either predominantly lateral column sense gone, but posterior column still there, or one side lateral column sense gone versus other side, posterior column sensations more diminished on the other side. And you can get more like a Brown-Sequard kind of a syndrome, although Brown-Sequard can happen with the cervical spinal cord extra outside cord injury, but a tumor inside spinal cord on one side can cause a Brown-Sequard kind of a syndrome, more motor loss on one side and sensory on the other side. That kind of a neurological picture indicate more lesion within the spinal cord than outside the spinal cord. But the final determination will lie on an MRI scan. I don't think neurologically you can confidently say that the paralysis is from inside the spinal cord and not from outside without those subtle changes that I just described. Does that answer your question, or do you have any other answer? Hello?
Rajiv, unmute yourself.
Can I add?
Sir.
Yes, sir. That justifies the answer.
Can I add that actually
Yes,
compressive myelopathy typical pituitary set as a lower motor as we are getting any tuberculosis or any condition. But in non-compressive myelopathy, here we will have dissociated sensation, that is touch sensation, persistent pain, and temperature will be lost.
I think that is right.
Yes. Anil Jain sir, please share your screen so we can have your talk.
Oh, yes.
Yeah.
You mean, now I got your point. I thought you were asking that compression within the cord versus outside cord, but you were right. If it is a central nervous system disease like the transverse myelitis or demyelinating disease, yes, you get a dissociative sensory loss like you just described. But it is not quite common term to my understanding, as a non-compressive myelopathy. It's a central nervous system disease, Is that what you are trying to point at?
I think if the intraspinal tumors, intramedullary tumors, they also behave like this only.
Yeah, that's where
Yes,
I
sir.
have already discussed that when you were not muted, but you can highlight it more. Why don't you go ahead? People are waiting to listen to you.
Yeah.
Yeah.
Okay. Thank you. Thank you. Sorry for all glitches. Dilip, thank you very much. I learned few new things today, and Dr. Kiran, it was very nice sequence of examinations being put forward. I think I'll be just restricting myself to evaluation in management in case of Caries spine. I think we'll start from here that it is a paucibacillary disease, and the implication of paucibacillary is that there is a low bacteriologic diagnosis and source detection. And if we keep that in mind, then it will help us in our diagnosis. Well, these are just general things that it is more common, 50% spinal tuberculosis. But things to understand for diagnosis, that spinal tuberculosis starts from inflammation, goes on to deformity and neural complications. So clinicians, patient will present to us in anywhere in the from the inflammatory stage to the complication, and we have to intervene at different points, and that we have to identify. So when you are making a clinical and radiological diagnosis, it is only possible if we are able to, if it is an advanced stage of disease. And this is the kind of a lesion which has a classical deformity and classical X-ray finding. But then by this time, deformity has already occurred, and maybe some of these patients may have a neural deficit. So the risk of having a delayed diagnosis in the stage of deformity are sinister. Now, for early diagnosis, suspicion has to be clinical or clinico-radiological. So any patient with persistent back pain 3 months or more, with or without tenderness or spasm which is localized, with or without constitutional symptom, should, and with or without some early radiological sign, should be screened with an MRI, so that, because that is the now gold standard. Now, if you look at this, 98% is a paradiscal disease, and this starts as an inflammation, and patients become symptomatic at this point of time. And as the inflammation continues, there is a subchondral weakening, and this starts herniating into the vertebral body, diseased vertebral body, and gradually this completely disc herniates. Although it may preserve, retain its shape and size, but these bones comes closer. Now, gradually there is an anterior height loss and becomes a kyphotic deformity. And this whole process takes many months, and patient is coming from this stage to the advanced kyphotic deformity when clinical diagnosis is obvious. So if at this stage, we may sometime get a slight reduction on the disc height on a plain X-rays, and that can be read as a reduction that any disc height should be equal or more than the height disc above. And if you keep this criteria, then this disc height is certainly less, has reduced, and that is what is a suspected inflammatory disease. And now at this point of time, with this clinical and radiological predictor, if we do imaging, it used to be a slides for an olden time, but to understand that why different imaging modality gives what observation, that on a bone scan, it gives a hot vertebrae, CT gives a destruction, but in the present time, MRI has become the gold standard. So a presumptive case where persistent localized back pain for 6 to 12 weeks with or without constitutional local tenderness and X-ray pointer, we need to evaluate with MRI. And this is what is the persistent presumptive case, where I find there is a slight increase in prevertebral shadow, and this spine is straight and losing the lordosis. And this is what is the reduction in this.
Sir, your voice is not clear.
So if you can stop your video,
Hello.
Hey, Anil, your voice is not audible, but if you can stop your video,
yeah.
then possibly will. Yeah. Oh,
I have stopped.
Can you stop sharing Anil Jain's screen so that he can then stop his video?
No, yeah, I have stopped it from here.
No, but we are still seeing Anil Jain's screen, and he could not find how to stop his video. Or maybe
Yeah.
Anil can leave the meeting and join back again.
Yeah, I think.
You can stop his screen share from here. You can do that.
Anil,
Stop share.
unshare your screen.
Over the top right side, he can unshare.
Because of the network issue, I think it has hanged.
That is
We'll
true.
try to stop it from here. Okay.
Oh, I'm sorry. It says you are viewing Anil Jain's screen. Now you have disconnected, Anil. So, yeah.
Yes.
So, Anil, now you have been disconnected. My screen is, my picture is here on the screen. So why don't you connect back again? Sure. Anil, the other option is share your screen, but mute your video, but you can speak over phone and I will put the phone here in my microphone.
Okay, I'll do that.
Just share the screen and mute your video, and I'll put it on speaker so that they can listen to me, your voice.
I'm sorry, Dilip.
Anil, just share your screen. Can you?
Sir, need to join again.
Oh, you have to join again because you disconnected altogether.
Yeah. I think he can join again and then he can only share the screen. He can share his screen.
No, can you join again?
In the meantime, can we discuss some questions here?
Okay.
Yeah.
Yeah, but people can listen to your voice because you are on speaker phone and my microphone is on.
Yeah, is there any questions, Sabyasachi? Just, yeah.
You can ask to Dr. Anil Jain because he can listen.
Okay. For a Carey spine case, whether in a history or in a summary, whether we can straight away tell the diagnosis that this is a tuberculosis spine, or we can say that this is a compressive myelopathy, most probably due to something. What should be the approach for the PGTs in such case?
So the question is that can we say on history that it is a case of compressive myelopathy?
The question was that after doing a long case, can they give the diagnosis that this is Carey spine causing paraparesis, or it is only a case of compressive myelopathy, but we do not know whether it is tuberculosis or not.
I think the best way is that if we say that it is a case of extradural or intradural compressive myelopathy, and quite possibility of then one can give one or two differentials. That would be the best option.
Did you get the answer?
Yes.
Yes, sir.
One can say that
Maybe Kiran sir can add.
if there is a knuckle or there is some prominence, then one can simply say that yes, now this is. Oh no, nothing is coming in this internet. So it's not getting connected.
So we can have question answer session. I think that will be the better way. Yeah.
Yes.
Yeah.
Okay,
So-
you can ask questions to Dr. Jain.
Jain, yes.
Yeah, I think, Dilip, what I can do is I can speak without the presentation as well, because there is nothing much to show.
Okay, why don't you go ahead do that? Yeah, that would be good.
I will do it that way because
Yes, sir. You just join the meeting and you can talk.
Yeah.
Yeah, keep your own screen for yourself and do the presentation by audio only.
Yeah. So
Go ahead.
what I was talking about, that once we have a classical, once we have suspected there is some destruction or some disease of the spine and we have got an MRI, there are certain characteristic MRI findings which one can see my review article in Journal Bone Joint Surgery British in 2010, which I can send the PDF again, that if there is a contiguous vertebral body involvement where adjacent vertebral bodies are inflamed, which have low signal in T1, right in T2, with the preserved disc spaces on MRI. While on plain X-rays we say reduction in the disc height, but here preserved disc height, relative preservation of disc. So what you call it, relative preservation of disc spaces, subligamentous extension in front of vertebrae, which is low signal in T1 and right in T2, large pre and paravertebral abscesses, epidural involvement, there is some encroachment in the epidural space of a connection, vertebral intraosseous abscess, again in T1 and T2 you get vertebral intraosseous abscess, and septate paravertebral shadows. These paravertebral shadows are septated in differentiation to pyogenic. So that's how, if you have a constellation of these 3-7 findings, then you are sure that you are dealing with a case of tuberculosis of spine. And these MRI findings are more or less diagnostic and almost 85 to 90% intensive. However, if you are not able to have this kind of a classical finding, and if on an MRI we detect one vertebral body is inflamed and then two vertebrae are normal, and then the other vertebral body is inflamed, then it is a diagnostic uncertainty, because here the differential diagnosis is going to be myeloma, lymphoma, and all other conditions. Hence, biopsy must be taken. There is no place for empiric treatment in spinal tuberculosis. I want to re-emphasize, you have to ascertain your diagnosis either by imaging or by some other method. There is no place yet. Now, so you have, once you have done the diagnosis, whether by imaging, if you are not able to do by imaging, then open biopsy or percutaneous biopsy must be done. Now, and you have obtained the tissue, then this tissue must be submitted for microbiological diagnosis, molecular diagnosis, histological diagnosis. These three are the methods by which you can make ascertain the diagnosis. Now here, I just like to say that diagnosis of tuberculosis is a hierarchical diagnosis. It is not straightforward diagnosis, because I said in the beginning, postbacillary, no bacterial count, and that is why any method, any laboratory method is not 100%. Say, for example, culture of tubercular organism, in best of the lab, the yield is 30 to 50%. Molecular method recently come up, little data present, but yes, 90 to 95% you are able to ascertain diagnosis in an acute disease. AFP sphere, 10 to 30%. AFP sphere in a bony lesion, spinal lesion is not, does not demonstrate organism AFP in more than 10 to 30% instances. Even the histology, it gives consistent diagnosis with granuloma, creating granuloma in 60% instances only. While in remaining 35, it is suggestive. there will be 5% instances your histology will be negative, or it's not suggestive of tuberculosis. But if you submit the tissue for all four, then in all 100% instances, we will be able to ascertain the diagnosis. So once the tissue is procured, tissue is submitted for all four. So that means that there is a very little scope where we can give ACT on physical suspicion. There is a very little scope where we can give on a radiological basis. But yes, with the MRI, we can start ACT. So this is what is a hierarchical diagnosis in an osteoarticular or a spinal lesion. Now coming to the treatment, the mainstay of treatment is ACT, and that is continuous multi-drug ACT. While surgery is indicated, type of surgery and indication of surgery in paraplegia or quadriplegia, in children, in granulomas, in late onset paraplegia, it requires individualized approach. So mainstay of treatment is ACT. And just not because, these points will be more clear if I'm able to show them some pictures. But anyway,
I do not have access to your complete article, but I'm sharing my screen and people can see the abstract of your 2020 JBJS article that you and Raja did put together.
That has that hierarchical, the diagram of that hierarchical diagnosis. That has that.
No, but I do not have the access to the full article. I can only show them the abstract that you authored with Raja together in 2020. Is that the one you are talking about? April 2020?
In that article, there is a triangle hierarchical diagnosis picture has been given. So that's a very useful picture to understand. And I think I will share that PDF to Rajiv so that it can be passed on to all.
If you email it to me, then I can open up that picture for them, if that is what you want to.
This internet is collapsed.
Oh, internet collapsed. Okay.
So now, as far as the drug therapy is concerned, when the new AGT came up, British Medical Research Council from 50 to 75 multi-center trials, from 750 patients in Hong Kong, Korea, Bulawayo, Rhodesia, and South Africa. There are 2 to 3 drugs: bed rest or ambulant chemotherapy, radical clearance or conservative treatment, and radical clearance or debridement were compared. And they concluded that it is a medical disease to be treated by ACT, and these makes not much difference in the outcome as far as outcome is concerned. Now, since then, the evolution of drug therapy has moved on. And there are 5 issues which are asked to everyone in the exam and which are asked everywhere, that what are the drugs to be given, what are the volumes to be given, should it be intermittent or daily doses, how long it should be given, is there any changes in the children, and failure of drug therapy if there is any. So first we need to understand the rationality of multi-drug, because in a tuberculous lesion, bacteria are of 3 types. One is extracellular, rapidly dividing, acted by INH, streptomycin, and indutol. Second is extracellular, slowly or intermittently dividing, acted upon by rifampicin. And third is intracellular, intermittently dividing, acted upon by the pyrazinoamide. So hence to all bacteria, you have to give a multi-drug therapy. The rationality of multi-drug therapy, alternate day or every day. I think that it was a long debate for last 10 years. Both are scientific. Lag effects work on the intermittent acts on the principle of lag effect, where if bacteria is exposed to a drug for 24 hours, the bacteria undergoes suppression. If the drug is withdrawn, bacteria remains under suppression for next 20 to 48 hours. And on that principle, thrice a week regimen was started. However, what has been observed in 10 years' time, that sometime if one dose is missed, then it becomes underdosing and it makes the patient prone for development of drug resistance. And that is why now every policy making body has decided that it is going to be daily dosing regimen. No more intermittent. It should be very clear it is a daily dosing regimen. Now the next issue was, and this was again going on for the last 25 years, 6 months, 9 months, 12 months, and this is going on because pulmonary people are very clear. They give 6 to 9 months. Why do they give? They are able to decide because they take sputum and they document the picture and then they give ATP. And the moment every month they take sputum, and the moment it becomes bacteriologically sterile, they give another 4 months, and that is why they are able to conclude that 6 months is good enough or 9 months is good enough. But in a bony lesion, particularly spinal lesion, you cannot ascertain the bacteriological sterility. And hence, you rely on imaging only, you rely on X-ray or you rely on MRI or other things. And that is why we have a problem in defining the endpoint of treatment. Now, that is why in all studies, the healed status, whether it is DMRC studies or all of that, healed status was taken as completion of regimen, that is 6 months or 9 months, with no reference for 2 years. So, I searched the literature about 4 years ago. What is the duration of treatment? What is the uncertainty in the literature? So, we found that there is a lack of consensus what constitutes healed status in the literature. So, points of treatment. And in a consecutive series of patients, these patients were evaluated by MRI. And what we noted is that only 35% patients attained healed status at the end of 8 months, while 60% at 12 months, 90% at 18 months. So we concluded it is unscientific to stop ATP by fixed time schedule. Issue remains still unresolved, and hence, and why it remained unresolved, I had some of the examples to show so that children could understand, but unfortunately I'm not able to show. What the observation was that some of these MRIs, they had shown healing of vertical body by fatty replacement in T1 weighted image. But on contrast, they were continued enhancement. Now, the point was that if there is a continuous enhancement, it is an inflammation of active disease or it is an inflammation of healing disease. And that is why we again took another series with a PET scan. And we again concluded, yes, PET scan is a better modality to resolve enhancing MRI controversy. Because in this analysis, we found that almost 28 of 28 demonstrated healed status by PET, while at that point of time, MRI were only 13 of 25. And particularly with the stainless steel implant, it is the PET is the only modality which can tell us about the healed status. So till today, but what we concluded that yes, we have to treat till we are able to demonstrate the healed status by any means. So, and there are some examples which I had put in for the children, but anyway, unfortunately, not able to show. So,
Anil, sorry for interrupting. I have pulled out your European Spine Journal article, and there is a picture of MRI scan, X-ray, axial cut, and CT scan, and I pulled it on the screen so people can view it.
Which article?
This is European Spine Journal article.
Yeah.
And this was published. This is a review article 2013, Anil Jain and Jaswant Kumar.
This was what was the instrumented stabilization or what was it?
No, this is tuberculosis of spine neurologic deficit. And you had one picture there in that article, and I put it on the screen so other can see. And that picture shows the X-ray, CT scan, MRI scan, but it doesn't have any caption in the picture for us to understand what it tells us about. Anyway, go ahead if you have anything to say, because you cannot see the picture.
So the current ATP is 4 drugs for 2 months as an intensive phase, and then rifampicin, INH, and ethambutol for next 10 months. Instability has been added in last 2-3 years because it has been reported from Gujarat that there was some monodrug resistance of INH. And that is why now in all regimens, rifampicin, INH and Instability for 10 months on daily doses. You need to monitor for progression of neural deficit, and you need to identify which are the patients require surgical intervention and intervene. So total duration remains 12 months, which is extendable to 18 months on case-to-case basis. Now then, coming to children, I think children is a different cup of different patient to be treated by ETP, because this ETP has to be measured and calculated based on the weight of the child. And by Indian Association of Pediatrics, they have given 4 weight categories: 0 to 10 kg, 10 to 17, 18 to 25, and 25 and above. So you have to, every visit, you have to calculate, measure the weight of the child and readjust the ATP. These are the 4 important aspects for drug therapy. Now, one is a failure of drug therapy. What do I mean by failure of drug therapy? That if on patient is on ATP, doesn't show clinical improvement or show radiological deterioration in terms of progression of kyphosis, in terms of developing a paraplegia, in terms of developing a new abscess, in terms of developing a newer lesion somewhere else, or if it is a post-operative case, then wound undergo dialysis. It means these drugs are not acting. And these are the ways we need to suspect that this patient is likely or might be having a drug resistance. And that drug resistance has to be handled. And let me tell you very clearly, there is a big number of drug resistance at the moment coming in our university. So drug resistance is something which we need to keep in our mind. Now, coming to paraplegia, early onset or late onset, the surgical indication in a cord compression is a dry compression, or if there is an instability, intending neural deficit. What these are, if there is a pan vertebral disease, a spotting disease, osteocomplex disease that can be ascertained on plain X-rays by obliteration of pedicle shadow besides the body disease, or on MRI if you see a gross destruction or inflammation of body as well as the posterior complex, then these spine must be stabilized, because these are the spine which are likely to develop neural deficit because of the translation of proximal spine over distal spine. And this is one thing, this neural deficit needs to be prevented by identifying pan vertebral disease. Now, the other indication is it is a long segment disease. 4 vertebral body, 5 vertebral body, and you have deep encrusted. Then this spine is unstable. You need to protect the graft, spanning graft by instrumented stabilization. Now, another indication of surgery is a deformity correction. I think this deformity now in last 15-20 years has been thought of very seriously. Some patients come to this spinal deformity, which is like
Hello.
I think.
No, I think you got disconnected. I'm calling him again.
I think what we can do, sir, we can have question answer session.
Anil, now you are back. You are back online. You got disconnected. Anil is back.
Okay, I'm back.
Yeah, you are back on audio.
Okay. Yeah.
You got disconnected by telephone.
Yeah. So, as far as surgical indication, instability, as I said, pan vertebral disease, and the second is a long segment disease. Now, deformity correction, if the patient presents with a deformity, already a deformity, and we know that if patient is allowed to heal in this deformed position, then anyone which has a deformity, heel deformity beyond 50-60 degrees, they are going to end up in a late onset paraplegia 10 to 15 years down the line. And that is why some of these patients which are in active stage of disease need to be surgically taken up for deformity correction. Because deformity correction in active disease is easier, simpler with less complication. However, in a heel disease, it is a very difficult proposition. So these patients for a deformity now must be taken up for surgery, and this indication, although some of these books may not be showing, but I think today we have added this indication for surgery at deformity correction. Now, children is again a very different cup of tea because these children, they have a very severe progression of deformity, even by growth. And Raja's work on this is very good. And that's the only work which tells very clearly that we need to identify in children which are these kyphotic deformities going to progress even after healing of disease. And that is those children must be surgically taken up to correct the deformity. Presumptive drug resistance, where we suspect drug resistance, must be taken up for surgery to take the tissue because drug resistance needs to be addressed. And as I said, instrumentation in TB spine, well, it is now, we know that whenever an infected tissue, pyogenic infection, you put an implant, there is a thick biofilm form, and that doesn't allow eradication of infection. And that is why pyogenic infection, metal is a problem. But in tuberculosis, biofilm form is a very thin. It doesn't stop penetration of HET, and hence it is compatible to instrument in spinal TB, whether ideally titanium, but even if it's stainless steel, then even then it works very well. So the indication of instrumentation are N vertebral lesion, where body as well as posterior complex is diseased. If there is a grossly unstable spine, long segment disease, then you have to protect the spine graft by doing a posterior instrumentation. If you have done a correction of kyphosis, then instrumentation is to be done. And TB of junctional area, because junctional areas are having more stresses on the vertebral body, is a junction of a mobile and a fixed spine. And junctional area must be instrumented, sterilization must be done. Type of instrumentation, whether you do a pedicle instrumentation, whether you do a hard shell instrumentation, whether you do a plate, depends on segment of spine, depend on if you use the correct principle. I have used all kind of instrumentation. Pedicle screw I have already used. I used in cervical spine plates anteriorly as well as posterior lateral mass fixation. Sometimes I have combined pedicle screw with the hard shell rectangle wire. If my proximal vertebrae or distal vertebrae starts throwing pus from the pedicle holes. So you can see some of these diagrams in some of my articles. So all instrumentations are okay, so long as you use the correct principle. Now, if everything is fine, even then, I consider a hard shell fixation is a very good fixation for a tuberculous spine because I'm taking a purchase against a healthy posterior complex while anterior disease bone is grafted. And this saves me 1 or 2 segments because in a pedicle fixation, you have to go 3 segments or 2 segments above or below. So I personally prefer a hard shell quite a lot in many cases. Then coming to spinal deformity, yes, issues are important. I have already told. But what is important that when it's a complex surgery, and the principle of spinal deformity correction is that you have to do an anterior disease corpectomy of the disease segment. You have to shorten the spine by doing a posterior column shortening. Now once you have done both, then spine is grossly unstable and hence you have to do an instrumented stabilization, anterior bone grafting, gap grafting, and the posterior gap grafting. So these are in principle of spinal deformity to be done by only those people who are well trained, well versed, and well experienced. Now, from spinal deformity, I just moved on to drug resistance. And in the drug resistance, as I said, once we have identified a suspected drug resistance, then line of action is 1, you have to prove your diagnosis. So how you prove your diagnosis? Take the tissue, get the histology or AFP smear, or molecular analysis, or culture. All 4 things must be done. you may find in some of these cases, because they are already treated by ATD, culture may be negative. In that case, genotypic analysis and histology, both of them are able to take us to diagnosis. And now line probe assays are available for 10 drugs, rifampicin and INH, gene expert for rifampicin only. So we are able to demonstrate drug resistance better, provided the diagnosis by histology is ascertained. Because molecular analysis alone is not sufficient. Molecular, I stress again here, molecular method demonstrates presence of genomes. And presence of genomes may be there in a healed lesion. And the example is that Egyptian mummies have demonstrated presence of genomes. So if histology is showing granuloma and your molecular method is showing resistance to rifampicin and INH or all other drugs, then we can start treating by the second line drug. Now, there are various definitions: monoresistance, where resistance to any one of the first line drugs, or polyresistance, where two or more first line drugs shows resistance, or MDR, where there is a resistance to rifampicin and INH, or XTR, where resistance to rifampicin, INH, fluoroquinolone, and injectables. Injectables other than streptomycin. So it is kanamycin, or it is for amikacin, or caprimycin, or all those kinds of things. Now, so there will be three situations. One is a suspected drug resistance, and the other one where you have proven drug resistance by histology, culture, or molecular method. Now, there will be third category, and which is not uncommon, that histology is positive, showing active disease, but culture shows no growth, and molecular is indeterminate. Hence, now consensus has evolved that we can treat it as a clinical drug resistance for MDR, for rifampicin and INH. Now, the principle of these chemotherapy, these drugs are less potent, more toxic, and expensive. They are used in higher number, often 4 to 7 at times, and may require hospitalization because these drugs have a lot of side effects. One should never add one drug to a failing regimen. So if you find there is a poor response to treatment, just add one drug. That should never be done. And preferably 5, but at least 4 new drugs must be added. They all should be given in a single dose, and there is no intermittent therapy. If you have got a culture report, no drug should be kept as a reserve. Ideal best regimen must be drafted out of the culture report, because this is the last chance of treating a resistant bacteria. And most important, patient must be counseled not to stop treatment even if discomfort present. Well, there are various regimens given that you give intensive phase for 6 months, 6 drugs, which includes aminoglycoside, which includes fluoroquinolone, which includes thalidomide, which includes any of the 2 drugs, pyrazinamide and or ethambutol or PAS or cyclothrin. And then kanamycin is stopped, or aminoglycosides are stopped after 6 months. Rest are continued for 18 months. So it is given for 24 months. Drug resistance treatment is for 24 months. Well, WHO guidelines, in my article, which Dilip has said that JBJS 220, the table is there where all regimens have been given, that if there is one drug resistance or 2 drugs, all those regimens have been given. But more important is prevention of drug resistance. And how you can do it, because the most common cause of developing a drug resistance is inadequate doses, inadequate dose regimen. And hence you should emphasize that first instance patient must be treated well, and one must monitor the drug response closely, so that prevention is better than treating the drug resistance. Now, coming to TB spine in children, I think you have to understand TB spine in children is different than the adults. Why? Because these children, they have a cartilaginous bone, and these bones just melt with the inflammation. And that is why the destruction is severe, rapid, and severe deformity progresses, develops. And that is why in children, you have a younger the child, more severe is the deformity, more severe, more rapid is the course. And that is why these children must be our suspicion index to diagnose must be very high. And I have an innumerable number of cases. I have put up very good one or two cases in this PowerPoint presentation where patient presented in a severe deformity and he was carrying an X-ray which was just 2 months old and which shows a very minimal deformity. So their progress is very fast and it must be taken care of. Our suspicion to diagnose must be very good. Now, next is that even if you are treated with disease spine and the disease has healed, some of these deformities going to progressively grow. Again, these progressive deformities must be identified and must be surgically taken up for deformity correction. And I think all those criteria of spine and wrist by Raja, they hold very true. In children, there is another phenomena which we have observed, that these severe deformity, even if you treat them by ATV and they're showing clinical response, sometimes these mothers come and they say that when child is lying down, spine is straight. When child gets up and walks, spine bends over and deformity it becomes more obvious. And the most common reason which we have identified that these turgid disc becomes a pseudo-orthotic between the proximal and distal parts of the spine. And that is why some of these patients we have to observe and take them for instrumental stabilization and anterior bone grafting. Well, if we do not take care of this issue in children, then this progressive kyphotic deformity, which progresses with growth and it ends up in a 60 or 70 degree, are the forerunner for late onset paraplegia. And that is why you have to take due care in active disease and not in the healed disease. You prevent the development of healed kyphotic deformity, severe kyphotic deformity, by acting better in active stage of disease. So friends, I'm so sorry because of this all internet issues and because I'm in a quarantine because of COVID-19 and my internet capacity is limited at this time. But the message which I try to give is that you need to suspect early, you need to treat early, diagnosis must be ascertained at all costs, treat adequately till healed status is achieved. Surgery is an individualized indication. Drug resistance is a menace, should be prevented, and if there, then should be treated aggressively. Children be little aggressive to make diagnosis and treat. I would say 3 suggested reading which for you is good enough. One is 2020 JBJS article, I think, which gives clear, which is very categorical statement has been given. 2010 British JBJS review article, a fresh look at the old disease. And third, Indian Journal of Orthopaedic, drug resistant spinal tuberculosis. You can download from Indian Journal of Orthopaedic. I can share this PDF with Rajiv. He can pass on to you. And the book which I have released 3 years ago, Tuberculosis, Bone, Joint, and Spine, where I have put 200 questions to myself as a postgraduate. I ask those questions when a patient comes to our OPD, how should I suspect one particular diagnosis, or how could I suspect tuberculosis spine? How should I move on, investigate it? How should we take a decision to start ATD? All those questions with the basis of literature has been adequately answered, and I think no question outside this is ever be asked in the examination and in the practice. I tried my level best unless some new question emerges, and I think this book is available on Amazon. So this could be a good reading material for all of you. Thank you very much indeed for patient hearing. And thank you very much.
Thank you, Anil. Thank you, Anil. Everybody highly appreciated your wonderful presentation. And they promise they will buy your book, not from Amazon, as long as it comes free.
Yes.
See, everybody is smiling at that.
Yeah. And
now I have one comment and one question on your multi-drug resistant tuberculosis.
Yeah, please.
So my summary or understanding is that multi-drug resistant tuberculosis will kill you regardless of what you do. A, the disease will kill you, and B, disease couldn't kill you, so you went to Dr. Anil Jain and he says 5 drugs every day for 24 months so the drug will kill you. And if you survive the drug complication, then the money will kill you because they're just so damn expensive for 2 years to continue. So whatever you do, you will be dead. Then why bother treating it?
No, Philip, I beg to differ because for last 5 years, I'm getting almost 50 patients per year of these kinds, referred from different places.
And are you treating them free of cost?
Yes.
Yes, government now has incorporated drugs in their thing. I have put in a lot of effort since 2000. I have gone to bring this to the authorities and published and taken out a lot of work on it. And now these drugs are, and you rightly said, my first patient, which I showed in 2000, I have gone in that conference to RNPCP people. I called all of them to sit on the first row so that I can put up these questions to them. That first patient which I treated had definitely sold his house. But after 8 years, the young boy came to invite me to that patient's marriage. 8 years after it, that patient is now perfectly fine. So the picture is not that gloomy. The only thing is that you have to have a perseverance with the patient. And now I have almost 100 odd patients which have been cured.
Sure.
But you need a very good laboratory.
No, I got a genuine question, not just being sarcastic about your presentation. This is like you mentioned about that you can find a genome and you can find even an Egyptian mummy presence of tuberculosis, but you cannot do any sensitivity testing or any what is called any testing of the drug, whether the bacteria is sensitive or not. But when you say a multi-drug resistant tuberculosis, you have to find the sensitivity to one or other different drugs. Then you have to have a positive culture. Is that correct?
Yeah. No, I'll answer your question. I understood your question.
I mean, my question is, if you cannot culture it, then can you still determine whether that bacteria is sensitive to any particular drug or not?
Yes, I'm coming to it because, Dilip, this is what I started. When I used to get a very poor support of laboratory, I was not able to culture them. And I used to suggest them that let us take some of these patients because they are histologically active. I know that full regimen has already been taken and there was no molecular support. So what we did, we used to treat them as a clinical drug resistance. And my first article was treating them as a clinical drug resistance. Now later on, I had a collaboration with National Institute of Tuberculosis. Their laboratory is very good. So they are able to grow the organism to almost 50 to 60% in samples, even now. Not have more than 50 to 60% in samples. Now, in those cases, what I say that if there is a histologically granule present, and then the genome present, which by gene expert for rifampicin and by line pro for 10 other drugs, rifampicin, INH, and 10 other drugs, then we are able to confidently ascertain the drug resistance. Because genome in the presence of histology with granuloma, granuloma in a lesion, from the lesion.
So if I understand you correctly, did you say that by gene expert technology, even if you cannot grow the bacteria, if you cannot culture the bacteria, you can still find out whether the bacteria is sensitive to rifampicin or not?
Yes.
Okay.
That is what precisely. But the only thing is that gene expert is not a test to be done for follow-up patients. I'll just give you one example. Last week, a patient came, which has already taken 18-month ATP. Now, there is a huge error. Now, the general surgeon took the pus and they got a gene expert done. I told them, and they said it is sensitive to rifampicin. So, when the general surgeon referred the patient to me, I asked a simple question, can you show me the pus? He said, no, I am not able to show. So then I put the needle again, and it was a very thick pus. Now, when I submitted this thick pus to microbial, to the gene expert and other methods, and the spear examination, then I'm sure that it is an active disease because the pus is very thick. I'm going to see some cells in it and the presence of genome by LPA and gene expert. Then the right diagnosis will come up for drug resistance, definitely. However, if it is a watery fluid and nothing else comes out except gene expert positive, then I'm going to take it as a sterile abscess.
Excellent. Any other question from other? Oh, sure. No, thank you very much. Let me give chance to any other person. Have any question? Rajiv, your microphone is on. Any other question?
No, sir. No question in YouTube. I think sir has covered every aspect of tuberculosis spine, starting from treatment and instrumentation and the diagnosis and everything. Rajiv da, you have got any question or Subhasachita, have you got any question?
We think we have no questions, sir. So thank you, Mr. Olinger, sir, for his excellent talk. But we missed the PowerPoint. I think we have another webinar for this tuberculosis spine. Whole webinar will be there, and I will request sir to please join on that day also. And now, may I request our president, sir, Professor Chinmoy, sir.
This is a very nice presentation. Dr. Dilip Gupta has covered almost everything on spine, which is required for the postgraduate students. And Dr. Professor Anil Jain also covered everything, including recent diagnosis and treatment of tuberculosis of the spine. So we expect the postgraduate students who have attended this seminar or webinar has benefited a lot. Incidentally, Dilip was with me during postgraduate in Kolkata. So, if you want, I thank you all again and see you in another program next time also. Thank you.
Thank you very much, everybody.
Thank you, sir. Thank you, sir.
Thank you, Dilip.
Have a good night.
See you soon.